Next subject. The subject is liver disease in general and cirrhosis. Next subject, the subject is liver disease in general and cirrhosis. So therefore, let us say what all things that cause cirrhosis, what do they all have in common? What do all things with cirrhosis have in common? They all are caused by fibrosis of the liver. What do they all have in common? They all are caused by fibrosis of the liver. So all things from cirrhosis, where the word for the rock comes out of rock or stone, skiras, for stone-like, because that's what your liver becomes, a stone-like fibrotic nubbin that doesn't do anything, because all the cells are dead and have been replaced by fibrous tissue, by fibroblasts, and by fibers in that tissue. So no matter what the etiology is, cirrhosis of all kinds is going to cause a decreased albumin. No matter what the etiology, cirrhosis and its symptoms is based on the severity. It's not the etiology, it's based on the severity. You'll hear that before. The low albumin leads to edema. The low albumin can help lead to ascites. The low albumin can lead to edema and ascites. So therefore, the low albumin is one of the causes of the edema and the ascites. The cirrhosis can lead to an elevation of the prothrombin time because all clotting factors in the body are made in the liver. All the clotting factors are made in the liver with the exception of factor 8. And von Willebrand's factor, yeah. Von Willebrand's factor is made in the endothelial cells. Von Willebrand's factor is made with factor 8 and stored in subendothelial cells in the vasculature. Prothrombin time. Well, even if the prothrombin time is elevated, we don't do anything about it except if you are bleeding. If you are bleeding, then we give fresh frozen plasma. If you're bleeding, we give fresh frozen plasma because vitamin K will not be effective and takes too long. Not be effective, vitamin K, and takes too long. One, not effective because if the liver was working, we wouldn't have a high prothrombin time to begin with. Second, even if it might work, it takes too long if you're bleeding. We need to reverse it immediately with fresh frozen plasma. Low albumin states making the edema and the ascites. The treatment for the low albumin states leading to edema and ascites, the specific therapy for the edema and the ascites of fluid retention from cirrhosis is spironolactone. Now, spironolactone is because the edema leads to intravascular volume depletion. Your juxtaglomerular complex and macula densa make increased renin, increased angiotensin 2, aldosterone. So it goes from renin to angiotensin 1 to angiotensin 2 to aldosterone. So therefore, all patients who have cirrhosis have high aldosterone states, and spironolactone inhibits the effect of aldosterone. Therefore, with the high aldosterone state of a person who is cirrhotic, aldactone, which is to say spironolactone, is the drug of choice because it inhibits that aldosterone. Now, what else do all people with cirrhosis have? They don't make albumin. They don't make clotting factors. They get various annoying skin things like spider angiomata like palmar erythema, spider angiomata, palmar erythema. They can get things like asterixis, which is a liver flap, an asterixis, where people are going, hello, can you say hello? Hello, hello. Flap, 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 flap. Oh, not good. Okay, ooh, my GABA's upset. Ooh, my neurotransmitters suck. Ooh, I've got too much accumulation of the worst neurotransmitters, and I'm flap, 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 asterixis. Is he waving bye-bye? No, I can't. Yeah. Asterixis. So, all people with cirrhosis get ascites, they get edema, they get high port thrombin time, they get increased portal hypertension. They get encephalopathy. Now, the portal hypertension can lead to varices. And if you have varices, you bleed. If you bleed, we band. If you bleed, we band. If you bleed, we band. A rubber band in the esophageal varices? Damn right. Better than sclerotherapy. Better than surgical shunting. Better than a Blakemore tube is banding. Crawl down your throat and put a rubber band around your esophageal varices. Yup, it's a lot better than bleeding to death. If you bleed, then you band. If you haven't bled, or to prophylax the next bleed, as prophylaxis against the next bleed, we give beta blockers. Beta blockers. We give beta blockers. As prophylaxis against the next bleed, we give beta blockers. So, you bleed, you band. You prophylax, you give beta blockers. Varices. Encephalopathy, to treat and prevent the encephalopathy is managed with lactulose. Well, encephalopathy from cirrhosis from which etiology? Cirrhosis from alcoholic cirrhosis? Is it going to be from alcohol that you're going to give that lactulose? Is it going to be from chronic hepatitis B and C that you're going to give that lactulose? Is it going to be that you're going to give lactulose for the encephalopathy from alcoholic cirrhosis? Is it going to be that you're going to give lactulose for the encephalopathy from primary biliary cirrhosis or from alpha-1 antitrypsin deficiency? Is it that it's going to be from the cirrhosis from alpha-1 antitrypsin deficiency from chronic hepatitis B and C? Is it going to be for the cirrhosis from Wilson's disease or from hemochromatosis? That word's longer than it used to be. I don't remember that word being that long. That word got longer just this morning. I used to have more room to put that word in there. I swear to God, that word only had like 4 letters in it just yesterday. Hemochromatosis, I swear, it's a much shorter word. Just yesterday, I could fit that in. It's like a 4-letter word yesterday. It only got to have that many letters just sometime this morning. It grew. The cirrhosis from whatever etiology it is, gives all of these things because they can all lead to fibrosis and obstruction of the portal circulation. 2/3 of the blood to the liver is from the portal vein. It's one of the only organs in the body of which the predominant blood supply is a vein. The blood going into it is a vein. Low flow, low pressure. If it's normally low pressure, that means fibrosis or obstruction can prevent the flow of blood into it. It's one of the few things. It's not like a brain, which is an arterial supply. These things, my carotids and my vertebral arteries back here, have high pressure. If you'd cut my head off, the blood would shoot up to the ceiling and would shoot up to the next floor. However, the vein flow of the portal vein is low flow and low pressure. Therefore, as the liver fibroses up, you will be much more susceptible to backflow problems. backflow into my portal circulation, backflow into my varices, backflow and causing ascites and edema and big liver and big spleen, big hemorrhoids, big spleen. And when you have an elevated spleen, why? You have a problem with low platelets. But don't transfuse platelets unless they are bleeding and have a platelet count less than 50,000. With bleeding less than 50,000, you will transfuse the platelets. Don't transfuse unless they're extremely low. That's just part of the condition of the disease. Second of all, if you're not bleeding and the platelet count is 22,000, what are you going to do? Transfuse platelets? Well, every 6 hours for the rest of your life? Well, it's not going to get better. If you're not bleeding, don't transfuse. Part of the hypersplenism is everybody gets a low platelet count. That's just part of the deal. Lactulose is superior to neomycin. Lactulose is superior to neomycin. Neomycin is a non-absorbed aminoglycoside antibiotic. Neomycin is a non-absorbed, not absorbed, aminoglycoside antibiotic. So therefore, if the neomycin is given, it kills the bacteria that cause the increase in ammonia. Ammonia encephalopathy. Now, everybody will say, well, it's not just ammonia. That's true, it's not just ammonia. However, if you treat ammonia, you can improve the encephalopathy. And besides that, what else do we know to treat? Lactulose and neomycin treat the things that we can identify at least. This is what everybody with ascites gets, portal hypertension, edema, ascites. And this is how you treat them in general. Now, the whole point of checking the ascites and to see what the albumin level is the albumin level is low in portal hypertension. The albumin level is low in portal hypertension. The albumin level is low when you have portal hypertension. The albumin level is low in the portal hypertension. So if the albumin level is low in portal hypertension, the difference between the serum and the ascites, the difference between the serum and the ascites level of albumin, the difference between them, if the level in the ascites is low, the difference between the serum and the ascites will be great. So the difference between them. Well, why don't we call it a serum to ascites albumin difference? A serum to ascites albumin difference? Because that would be abbreviated as a serum to ascites albumin difference. Now, gastroenterologists are fundamentally happy people. You got to have a good sense of humor to spend most of your day crawling through people's anuses and spending all day long looking at stool in the colon. So they're fundamentally, I think, relatively happy, chipper people. So they didn't want to call it a serum to ascites albumin difference. That would be a SAD. Did you check the SAD? Oh, they have a high SAD. Oh, they have a high SAD. Well, that's sad. No. Well, they're happy people. So instead of calling it a serum to ascites albumin difference, it's called a serum to ascites albumin gradient. And the serum to ascites albumin gradient, a SAG, at least it sounds like it's a lot more cheerful than saying the SAD for people. We leave all the unhappy acronyms to the hematology oncology people who are chopping and mopping and cop-blamming and cytobombing and all the other bad acronyms. The SAG is increased when you have portal hypertension. The gradient is increased because the level in the ascites is low and the level in the serum is higher. So the gradient or difference is increased, greater than 1.1. In other words, if the ascites fluid was the same or high, the same as the serum, the gradient would be low. Low gradients between the serum to ascites albumin gradient being low is things like cancer. Cancer gives a low gradient because cancer puts more protein and albumin into the ascites. Portal hypertension gives a high gradient, a greater difference, because the amount of albumin in the acidic fluid is lower. And that is the fundamental difference. Hey, I got a big belly full of ascites. What's that from? Well, I don't know. It could be everything from Meigs syndrome to portal hypertension, cancer, tuberculosis. It could be hypothyroidism. It could be albumin losing, malabsorptions in the gastrointestinal tract. It can be all kinds of things from TB peritonitis, secondary peritonitis, spontaneous bacterial peritonitis, portal hypertension, hepatoma, peritoneal carcinomatosis, ovarian cancer, pancreatic cancer, colonic cancer. Ooh, too much information going through my brain. Too much information driving me insane. Oh! All of the cancers have high albumin levels, and the SAG will be low with cancer. All the things that cause portal hypertension, such as all the many forms of cirrhosis, will give a high serum ascites albumin gradient, which is to say portal hypertension, and the SAG will be high. And that's the difference. Now, the SAG does not tell you necessarily while you have infection. Some infections will have a high one, some a low one. Secondary peritonitis, in other words, I got a hole in my belly, I perforated something, TB peritonitis, give a high albumin, which is to say a low gradient. So certain infections will go here. Spontaneous bacterial peritonitis will go here because in spontaneous bacterial peritonitis, there is a low albumin level. A low albumin level. So spontaneous bacterial peritonitis will go here, and spontaneous bacterial peritonitis is fundamentally based on whether or not you have a high number of white cells. Greater than 500 white cells, SBP. 500 white cells or greater than 250 total neutrophils. And that will mean it's time to give the Ceph